Thank you for joining. We're going to go ahead and get started. So I'll begin by muting all phone lines. Speakers, please remember to unmute yourself.
The leader has muted your line. To unmute your line, press #6.
Hello, everyone. Thank you for joining us for today's webinar, Reframing Healthcare, a Racial Justice Lens. Before we get started, I'd like to go over a few housekeeping items. This call will be recorded for training purposes, and we'll provide you with details on accessing the recording at the end of the webinar. As you all heard, the phone lines are on mute for the duration of the presentation. We will address questions at the end, and we'll let you know how you can unmute your line at that time. Or throughout the presentation, you can enter your question in the chat box at the bottom right of the screen. I've also put a link in chat to where you can find the slides for today's webinar. So without further ado, I'm going to pass it over to Karen Evans to get us started.
Good afternoon. Welcome to Reframing Healthcare, a Racial Justice Lens. This is Karen Evans with the New England QIO. We are passionate about the work being done using racial justice to inform strategies to improve health outcomes. The New England QIO is partnering closely with the Massachusetts Department of Public Health, the Boston Public Health Commission, health plans, and community-based organizations to support community health centers across Massachusetts to serve patients at high risk for poor outcomes. We've started a 5-year project to improve hypertension rates and diabetes outcomes in pilot community health centers using a racial justice lens. Today, we're grateful to have speakers from the Boston Public Health Commission and Massachusetts Department of Health. You turn the next slide, to share some understanding and history of structural and institutional racism and the racial justice training being offered to organizations and communities.
Hold on a second, Karen. Emily or Jennifer, I'm having difficulty advancing the slides.
Okay.
Well, hold on one second. Emily or Jennifer, are you on the line? Why can't I advance the slide? Emily or Jennifer, are you there?
Morgan, we could try passing it back to Kate and see if she's able to.
Yeah, let's do that. Kate is not promoted right now.
Oh, no. Pending.
Oh, okay, I got it. Whew. Go ahead, Karen.
Okay, today we're grateful to have speakers from the Boston Public Health Commission and Massachusetts Department of Health to share some understanding and history of structural and institutional racism and racial justice training that's being offered to organizations and communities here in Massachusetts. Southern Jamaica Plain Health Center will share their journey that they started 10 years ago to offer practical, real-life examples of ways these issues are being addressed on a day-to-day basis to improve health outcomes. We hope to have a few minutes at the end of the webinar during which you're welcome to ask questions of any of our speakers. You can write questions in the chat box anytime and we'll address them at the end as time permits. And feel free to include the speaker to whom you're addressing your question in chat. And that way, if we run out of time, we can route all the questions to the speaker you specified so they won't be lost. Now it's my pleasure to tell you a little more about our speakers. Mark Kennedy is the Senior Program Manager for the Chronic Disease Prevention and Control Division at the Boston Public Health Commission. He's a member of the Comprehensive Cancer Prevention Screening and Prevention and Control Steering Committee and co-chairs the Prostate Cancer Work Group for the state of Massachusetts. Mark is developing population-based communication strategies and interventions for screenable cancers and chronic diseases. He also co-leads the Community Engagement Work Group for the Boston Breast Cancer Equity Coalition. Mark spent several years at the Dana-Farber Institute managing the Blum Community Prostate Cancer Education and Screening Program. Max Alderman is the Diabetes Program Coordinator at the Massachusetts Department of Public Health. He leads the efforts to scale and sustain the Diabetes Prevention Program throughout our state, as well as providing subject matter expertise and technical assistance to healthcare and community-based organizations with clinical community linkages. Max is a trained Diabetes Prevention Program lifestyle coach and has worked at the YMCA of Greater Boston, where he served as a coordinator for the Federal Racial and Ethnic Approaches to Community Health REACH grant. Tom Kiefer has served as the Executive Director of Southern Jamaica Plain Health Center since 2001. He's worked in Boston Health Center since 1977, first as a clinician for 15 years, and then in administrative roles at Whittier Street, Mattapan, and Southern Jamaica Plain Health Centers. Under his leadership, Southern Jamaica Plain Health Center has expanded its community programming and partnerships, especially in the areas of youth and senior programs, and has become a leading voice and model for promoting health equity and racial justice in healthcare systems. Tom also has extensive experience with housing issues as a community organizer and board member of the city-wide Vida Urbana with a focus on health of public housing residents. And Jamie D. Zambascantita is a primary care physician and the medical director of Southern Jamaica Plain Health Center, where he's worked the past 15 years. He's currently working in the Pursuing Equity Collaborative and has participated in LGBTQ projects at the Brigham and Women's Hospital in Boston. Dr. D. Zambascantita did his internal medicine training at the Naval Medical Center, Portsmouth, and is originally from Puerto Rico. Now I'll turn the presentation over to Max and Mark.
Great, thank you, Karen. So just wanted to start with a little bit of definitions and history to provide some background for the talk today. And so to start off with, what is racial justice? And so this definition comes from Barrio, Love, Ortiz, Vermagro, et al. And it says that the systematic, fair treatment of people of all races, considering the impact of historical and structural oppression, resulting in equitable opportunities and outcomes for all. And next slide. And so there's a lot of racial justice terminology that's kind of being used and kind of get buzzwords. So I just wanted to talk a little about some of the distinguishing differences between some of the terminology. And so when we talk about racial justice, that doesn't really equal diversity, right? So you hear a lot about hospitals having diversity programs, but diversity really equals variety. So it's not really what we're talking about in terms of racial justice. Also, racial justice isn't really the same as equality. Equality is sameness. And when we're talking about racial justice, we're really talking more about equity, which equates to kind of fairness and justice. And so you might hear the terms racial justice and racial equity intertwined, and we'll go more into kind of that difference between equality and equity and what that means in a later slide. So next slide. And so one more distinction factor is just between the terms disparities, inequalities, and inequities. And you hear this a lot in healthcare in terms of what we're talking about health disparities, right? And so what do we actually mean when we're saying health disparity, and what's the difference between a disparity and an inequity? So a disparity really is an inequality, right? It implies that there is some difference between two groups. And so use an example from diabetes. So folks who are 65 plus have higher risks of developing type 2 diabetes, and we know that as folks get older, the risk increases. So someone who's 75 compared to someone who's 35, that is a health disparity, right? So there's a difference between the people who are 75-year-olds that have their risk of diabetes versus those who are 35. And that is a biological difference, and it's a difference in terms of outcomes, right? But when we're talking about inequity, yes, that's also a difference, but it's a difference that we feel is as unnecessary and avoidable, but it's also considered unfair and unjust. So when you look at a 75-year-old man or two 75-year-old men, one being white, one being black, and there being a very big difference in terms of their chance of developing type 2 diabetes, there's no biological basis for that at all. So that's what we call an inequity, something that is unjust or unfair. And next slide, please. And so just an example to kind of between the equity equality difference. So imagine going to a rock concert at a stadium and it being let out, and what do you usually see in terms of the restrooms, right? So there's usually an equal distribution of restrooms for men and restrooms for women. But what usually ends up happening in this scenario, right? We usually see a long line outside the women's room, whereas the men's room kind of seems to go in and out. And so this, you could argue, is, while there's an equal distribution of these two rooms, it may not be equitable, right? So this isn't working for everyone. And you could even argue that this isn't working for the men either, right? Because the men have family too. They have partners that might be using the other restrooms, and so what do? They have to wait, right, for their partners to finish the room. So you can argue that the equality of distribution of some resources doesn't really work for people, and so that's why we're really trying to push towards equitable resources for folks in terms of making it more accessible and giving people what they need. Okay, so next slide, please. And so we can't talk about racial justice without talking about racism. Okay, and so this definition of racism is a few out there, but we really like this definition from David Wellman, which classifies it as a system of advantage based on race. Okay, so it's a system of advantage based on race. And you'll see why framing racism as a system is really important when we talk about the different levels that racism acts at. So next slide, please. And so there are generally 4 kind of levels of racism when you break it down. So the first being internal racism, which is basically internalization of racial oppression and racial hierarchy. And an example of this might be a person of color believing that they are part of an inferior race, right? So it's buying into this societal racial oppression and hierarchy. Whereas interpersonal racism is basically what we mostly think about when we think about racism, right? That's kind of the explicit and implicit negative attitudes that are exchanged or expressed between people in society. And so what's really important is to kind of get beyond some of those levels, or kind of considered the micro level, and into more of the macro level of racism. And then you start to do that with institutional. And so institutional racism is essentially the kind of social and political institutions that perpetuate discrimination and injustices. And a prime example of that, so we see this in housing systems and in healthcare and education, transportation, and particularly in the criminal justice system when you see a disproportionate representation of people of color who are in the criminal justice system compared to white folks. And then lastly is structural racism, which kind of ties all of them together and can be seen as really the most harmful and probably least discussed form of racism. And this is because it's really systemic throughout our society and sometimes can be really invisible to see. And so we'll talk about, if you see the next slide, you'll see how structural racism, again, really permeates all aspects of what's called a kind of socio-ecological model. So all the way from the individual lifestyle factors, from social and community networks, what we consider the social determinants of health in terms of the living and working conditions, and the cultural and environmental structures that we live in. So it really permeates all, and which is why we really try to move the conversation to the systemic level when we talk about racism. And so next slide, just leave you with a few examples of how historically these systems of discrimination and injustice have really permeated society and left long-lasting impacts, right? So starting with and it goes way before this, but just again a few examples of Jim Crow, which started in the 1890s, being mandated racial segregation, lasted until 1965, right? So a lot of this has been happening for a really long time, and so it took a long time to develop these structures of racism, and so it's they have to be dismantled, and it takes a long time to do that. Another example being the GI Bill in 1944 for returning World War II vets. This was a great program in some ways in that it helps vets get loans and for education and homes, but what's not talked about so much is blacks were basically excluded from the housing provisions, and this had a huge impact in terms of home ownership moving forward from then on. And then lastly, redlining, and that's you see an example of this from the Boston area. Which basically, although banned now, would actually bar people of color from getting loans and actually moving into certain neighborhoods, basically not allowing them to live in the suburbs and in certain neighborhoods in Boston. And again, even though this no longer exists today, we still see the impacts in our neighborhoods of Boston to this day, and how we know that has also led to other types of segregation, discrimination, and health outcomes. And so with that, I'll pass you over to on our next slide, our next presenter, Mark Kennedy, who will talk a little more about what that looks like at the city level from the Boston Public Health Commission.
Excellent. Thank you, Max, and hello, everyone. Max, let me amplify your comments by moving from the conceptual to the real in terms of how race impacts health. And the context that I've chosen to focus on is breast cancer. I just want to mention that in the year 2005, a group of Black female breast cancer survivors partnered with the city of Boston and formed a group called the Pink and Black Ambassadors. In 2005, the issue was low rates of mammography in Boston's Black community. The ambassadors visited schools and other community-based organizations to raise awareness about breast cancer and to educate about screening. Next slide, please. And these data are from a recently released first ever Health of Boston special report that talks about cancer. I'll talk about that again in a few slides. But today, Black women have the highest mammography rates in Boston. Overall, mortality from breast cancer in Boston has declined, but outcomes are different when we look at race and ethnicity. Next slide, please. Despite overall decline in mortality, Black women are still dying from breast cancer at a rate that is 20% higher than for white women in Boston. And this slide covers the time period between 2001 and 2012. Next slide, please. And this slide depicts mortality for the period from 2011 to 2013 combined. You can see that the mortality gap from breast cancer between Black and white women is closing. But, next slide, please. Premature death from breast cancer, that is, death before age 65, represents a much larger disparity. Young Black women are dying from breast cancer at a rate that is 78% higher than for Black women in Boston in this age group. Next slide, please. As we contemplate why, I want to relay a description of a real scenario that depicts one of the many ways that this disparity looks on the ground. Lost in the Maze is the title of an article that was published in October 2018, yet last month, in Nature Medicine, which is part of an international journal of science called Nature. In 2003, a Haitian woman represented at a Boston hospital with an aggressive form of breast cancer. She had her lumpectomy to remove the tumor before she went to the hospital that day and was there to discuss follow-up. But she didn't follow through and have the chemotherapy and radiation, which are standard after surgery to reduce the risk of recurrence. In this case, the reason why those procedures weren't done was not because they weren't offered, but because the woman was a single parent to a young girl. And as the sole provider for the family, she needed to keep working in order to support her daughter. 2 years later, she went back to the same hospital, saw the same doctor, who recognized her name even after 2 years. And at this point, she presented with a giant open wound where the lumpectomy had been done. Without having had the proper follow-up treatment, the cancer had gotten worse. She did have the follow-up treatment at that point, but it was too late, and she died a few months later. Next slide, please. The Boston Public Health Commission has an organizational structure based on function, and the Office of Health Equity is part of our senior leadership team. Our approach to public health focuses on racial and ethnic inequities, and this affects how resources are focused and on our approaches to upstream issues. Our Anti-Racism Advisory Committee, ARAC, is one of multiple elements of Boston Public Health Commission's Racial Justice and Health Equity Initiative, and this was established in 2008 to align Boston Public Health Commission programs, policies, and practices within a racial justice and health equity framework to build the organizational capacity to effectively reduce inequities across the city. Committee members review, assess, and develop internal recommendations, and design and implement internal initiatives to achieve this. This committee represents all of our 6 bureaus to ensure that the work of ARAC is informed by staff. Next slide, please. I just referenced the report earlier in my comments. Earlier this year, the Commission released the first-time supplement to the biannual Health of Boston report, which is called the Health of Boston Special Report, Cancer Among City of Boston Residents in the Years Between 1999 and 2013. This document contains information on activities and trends based on behavioral risk factors, trends in screening rates, trends in incidence and mortality rates for all cancers, then with a focus on cancers including lung, female breast, prostate, colorectal, and liver cancers. And it also includes recommendations for strategy and planning purposes. Also, we have a newly formed Cancer Advisory Group here at the Commission. And this group is a multidisciplinary partnership to inform the Commission's development and implementation of strategies to reduce the burden of cancer in Boston. And the one thing I also want to mention, because I mentioned proudly the Pink and Black Ambassadors a few slides earlier, but that group was relaunched in 2017 as the Pink and Black Education and Support Network. And this basically is done to make female breast cancer survivors aware of local resources that support survivorship and to identify local initiatives on which they can work in service to others. There are a number of other things that we support, again, including work that we do with the Department of Public Health, with Dana-Farber and other partners in the Boston Breast Cancer Equity Coalition. That coalition actually led to the funding of a massive translating research into practice, which is a 6-hospital collaboration to improve outcomes for breast cancer mortality in women of color. And we also, of course, support the mobile program out of Dana-Farber, which is the mammography ban. And at this point, Max, I'll turn it back over to you to finish our portion of the presentation.
Great, thanks, Mark. And so, just quickly go through, we as Department of Public Health is really built off of what Boston Public Health Commission has started in terms of our approach to racial justice work here. And really just in the last 3 to 5 years have we really started to pick things up. And what we like to take, what we say is kind of an inside-out approach. We realized that we had to look internally first at our policies, systems, and practices before hourly working with our partners. And so we started, like EDHC, with many racial justice trainings that involved 2-day workshops and half-day labs to really get folks, more up to speed on the terminology and starting to really normalize conversations around race. And out of that, we formed our own racial equity initiative, which tackled through working groups different areas around professional development, operations, procurement, evaluation, communication, policy, places where we think that we could really make strides in terms of how we can incorporate addressing racial equity and integrate it into the work that we do every day. And so the next slide just has our why statement that was adapted by one of our bureaus, and I won't go through it all with you, but this is just one example of how our bureau has expressed our commitment to addressing racial equity, and in particular how we lead, explicitly with race, but not exclusively. And one of the first parts is really acknowledging racism and and this is really just a start of how we can better integrate this work into our system. And it is a journey. It's not going to be perfect, and it's something that we continue to move forward with. And we hope that you folks on the call today, join us in this journey. And it'll be great to hear from Tom Kiefer and Dr. Z. So I'm going to complain more from them in terms of how they're doing it on their organizational level.
Okay. Hi, everybody. This is Tom Kiefer. Just to add a couple things at the beginning. I am a white guy. It's on my picture there, but we just like to be explicit about who's talking and our identities as we do this work. And also, another thing to add as we start is how much of our work was inspired by the Boston Public Health Commission years ago. We learned so much from them. So, especially since Mark's on the call and on the speaking today, we want to acknowledge that.
Excellent. Thank you, John.
Hi, ladies and gatita. I'm Puerto Rican, which is a mix of races, and I'm happy to be participating. Tom.
Okay, so do I have control of the slides now, or I need to ask you guys?
You have control. You can use the page down button on your keyboard to advance the slides.
Okay, I'm not having any luck with that. So
try the arrow then? I'm not sure. Yeah, this is the same problem I was having at the beginning. I apologize. Emily or Jennifer, are you on the line? Oh,
okay,
it moved.
we're all set.
Okay, good.
My technical expert here, Jaime, fixed this one. Okay, so just also to let you know that the slide you see there is a screenshot of a video that was produced by partners this year in the spring. It's a 9-minute video that was produced for the Partners Diversity and Inclusion Summit that features our health center and the work we've done here. I'm not going to be able to show it to you today, but the link is on there too. We'll try to get the link to you if you want to spend a couple minutes seeing, pictures and visuals of what we're talking about today. So, equity and justice. These things the same? I think in our professional life we tend to talk about health equity. It's a more neutral word. It's not political. It's maybe more professional. I am starting to hear people talk about health justice. A lot of them are outside of the health world. But to me, justice, it's a more human word. It has more power. It's the kind of thing you put on your protest sign. It has more urgency, and I think we need to be urgent. The issues, the inequities we're talking about are life and death issues. People are dying, and so if we're going to use the term health equity, which is the term that we use in most of our work, I don't want us to lose the power, the urgency, the kind of humanity that the word justice has. So I kind of keep that in my head as I talk about health equity, because this is an exercise of head and heart. Okay.
So just to review the goal of our talk, we're going to start with a review of our organizational journey, which began 10 years ago. We'll explain the key concepts, so we've heard some similar definitions already of what the terms we've come to use. We'll show you a couple of examples of how we've translated that work into those ideas into our work, and giving examples of how you would reframe a problem using this social justice frame. And then overall, that is to hope to spark some ideas and strategies for you who are attending this conference. So Southern Jamaica Plain, this is who we are. We're a community health center. We're hospital licensed, being part of the Brigham and Women and Partners, not a federally qualified independent one, which both gives us access to partners health care and what means that we have some difference from the other community health centers. We're located in Jamaica Plain, and our population is 50% Latino, and many of them are historically of Jamaica Plain, but throughout the gentrification have moved to surrounding neighborhoods. 15% African American, about 35% white. Of our 13,000, we have 13,000 patients, 13 primary care doctors, and 85 staff. As I mentioned, our neighborhood characteristics have been changing for some time due to different immigration, so that our diverse population includes now Dominican Republic, Central Americans from Puerto Rico, and then increasingly other parts of the world, Haiti and East Africa. One of the interesting things about Jamaica Plain is that although the city itself is, Boston remains sort of segregated, we're more diverse than the rest of the city, and it's a place where people can interact with each other on a regular basis.
Okay, so it's Tom again. So I'm just going to go through some of the chronology of what our journey has been since around 2006. At that time, one of the things that was happening actually at that time was the PBS documentary Unnatural Causes came out. which you can still access from PDF or at your library. It's a series of 8 shows that really popularize some of the public knowledge about inequities, both racial, class, and other inequities in healthcare, in a very dramatic way, and to the extent that there were community forums about it. We pulled together our board and some of the leaders of the organization and to really explicitly talk about it. If we're learning that only 15 or 20% of our health outcomes of our lives are coming from healthcare, then what about the other 85% or 80%? What are we doing about it as a community health center? So that was an inspiring thing that got us started, and we had a chance a year later to get a small grant through the Boston Public Health Commission to develop a neighborhood partnership to address health disparities, and we chose to look at health disparities impacting youth. We wouldn't be using the language health disparities today, we would call them inequities, but this is what our language was in 2007. And what we found, as we did a series of summits around social determinants of health, around housing, transportation, food, and so forth, and for each one, bringing youth into the room and looking at the health futures of our young people in Jamaica Plain, we found some striking things. One that we kind of already knew. One is that there's really 2 Jamaica Plains. There's the affluent white side and the less affluent side with mostly people of color. And the health futures of our youth corresponded to that. On one side, the kids were doing great. They were working in their parents' lab during the summer. They were going to Boston Latin School. But on the other side of our community, their health futures were not so great, and they were destined to not live as long or have as good health as adults. We also found that we were learning for each of these social determinants about housing, we were learning how much the history of racism in this country has contributed to the outcomes that we have today, where white residents tend to live in more affluent housing, they tend to own it, they tend to have more wealth, they tend to eat better food, go to better schools. And behind all these social determinants was racism. And so in following this string of what we were learning, we tended to focus more and more on understanding structural racism, how that impacts health. We brought together young people in 2009 in a project called Racial Reconciliation and Healing, which still continues today, where we bring about 20 young people together every academic year. They come here twice a week after school. They're half white youth and half youth of color, and they learn about public health, epidemiology, racial identity development, history of racism, and sometimes they work together, sometimes they separate into two different groups and then come back together. So it's a real life-changing experience for these young people to go through it for a year. We think it has a huge impact on their health as adults too. And we learned so much from that we have brought to our work with adults, with doctors, with community residents over time. That same year, we had developed a training for our community partners, the housing organizations, the education and employment organizations. We decided to just open up that training to the community. So we've been offering that training for almost 10 years now that almost 3,000 people have gone through. And the people who come are students, medical students, residents, community residents, people from other organizations, people that we meet in our travels and in our work that we invite them to, that helps to give some basic data about health outcomes in Boston and how much of it is related to structural racism. We spent, in terms of learning about all this stuff, the next question was, well, what are we going to do about it? So we did a couple of year-long projects focused on that were really chosen by our young people. One was on youth employment, and we really tried to work on youth employment as a health issue and how much youth employment impacts the health of young people over their lifetime. And we also worked on sex education in Boston Public Schools. And then we looked at a bigger project. We looked around the country and saw in Seattle an example where the whole city government has chosen to create a commission for social and racial justice that brings together all the city departments that each have to bring in a plan for how they're going to promote racial justice in all their policies. And so we really pushed and spent a year working on bringing that to Boston and getting Boston to join that organization, the Government Alliance for Racial Equity, which they ultimately did. So a lot of policy work too. In 2014, we really started focusing more on our own organization, like how are we working internally. We developed a staff compact. We started bringing all of our staff to this training and all of our new staff, and talking about our policies. Let's start working through our policies with a racial justice lens. And then over the years, many docs came to our trainings, and at the end of the training would come up to us and say, "This is really compelling. Well, what does it mean for me as a doc working in the exam room?" And ultimately, 3 years ago, we brought together a group of doctors that are really committed to racial equity to try to figure out an answer to that. And we've made a lot of progress, I think, but it's still very much a work in progress at the same time. Over the past year and a half, we've been invited to participate in IHI's National Learning Collaborative called Pursuing Equity, where they brought together 8 organizations around the country that are doing equity work to try to have, in a 2-year learning collaborative, to try to really pull together how we're doing it and what's the content of it. So that's some of our journey in a nutshell. And just to show you kind of what our racial justice program looks like, on the left you have here our staff training, our policies, our patient care, our community programs, what we're doing at the health center, and then the more specialized programs on the right, the Youth Racial Reconciliation Healing Program. For providers, the program is called Adaptive Leaders for Racial Justice. That's the one that's looking at what happens in the exam room. Working very much inside of our hospital, Brigham and Women's, in terms of participating in equity efforts there in a whole number of ways. Being part of the National Learning Collaborative, continuing to do our training, and we're not only doing an open training, but we're also going out and training a number of other organizations around the city and state, and even some around the country, in some of the concepts that we're using and the work we're doing. And finally, still striving to be involved in policy efforts that promote system change. And this is our way as a public health entity of working upstream, is trying to do a little piece of policy work in every arena that we're in.
So why is this work about community health centers? So for those familiar with the history of community health centers, public health has always been a part of that mission. We've also learned in our journeys, as Tom just discussed, from other people who are doing this work. In our health centers itself, we've developed a core of leaders, each of us, who has taken on a role in advancing this work. And from a medical point of view, we see this as crucial to providing high-quality care to our patients and community. You can't have safe, quality care without equity. And then this is where our head and our hearts are leading us, right? Keeping it real here. So in our approach here, some of this is review. So we also use David Wallman definition of racism. We see it as structural. The groundwater analogy is interesting and appropriate. If you see a fish is dead, you might think the fish itself is sick. If every fish in your pond, you think it's something in the water. But if you look around and every pond has dead fish, then it's widespread. It's in the groundwater. It's seeping throughout. And I think that's how we think of racism. We mentioned it's not an academic exercise. It's more than diversity. And then another part which is important is that both white people and people of color have a role to play. The white people shouldn't just be inviting people of color to join them in the perfect world. So it shouldn't be the people of color's job to be begging for their seat at the table. Everybody needs to work within their own group and together. We always have found it's important to make sure that people don't personalize the critique of systems, or we keep it at a system level. But we do want to make it personal. We care about this and we have a passion.
Okay, so let's go through a couple of examples of our work. First of all, I'm sure all of you are working on social determinants of health, and so this one example relates to how we approach transportation as a social determinant of health and what are we going to do about it. So the traditional approach, patients that we have that keep missing their appointments because of transportation, we see the patient as the problem. The patient is needy, they can't get to their appointments. We're sympathetic to their needs. And what we do is try to find a solution for them. So we'll get them the ride or a lift or a cab. In our alternative framework, a racial justice or structural racism framework, we don't see the patient as the problem. We see the system as the problem. We start from a different spot. So the transportation system in Boston is racially redlined in the sense that most transportation dollars are spent for the commuter rail to bring in suburban whites. The bus system, largely used by people of color in Boston, gets a lot less funding. And these transportation inequities are really closely linked to historical processes that Max was talking about before. He actually showed the same map of redlining. These are the processes that intentionally created better housing, better jobs, more wealth, more rights. So we're approaching it with a different framework. So you see a couple of maps here. The one on the left is the redlining map from 1936. The one on the right is it looks like a transportation map because it's the public transportation system in Boston, showing that people who live in different neighborhoods have very different rates of diabetes. But actually, if you overlay this map or the maps of chronic disease or other health maps over the redlining map, you're going to see that the same historical processes that happened back in the 30s or back in the late 1800s have produced the differences in our neighborhoods and the inequities that we have today. So, back to transportation. What does it look like? Here's just a couple of visuals of what our subway system looks like on the left. That's a bus stop, and the bus system that serves most of the communities of color in Boston is very much inadequate. And it's a picture of the commuter rail bringing our workers in from the suburbs. So we try to do a policy piece to address transportation inequity. We brought together 14 health centers in 2015 and surveyed almost 1,000 patients. And what we found out, I'm not going to go over the data on here, was that, yes, Black and Latino patients miss their appointments more often than white patients because of transportation problems. But we were also shocked, and so were the other health centers, at how many of all of our patients miss their appointments because of transportation problems. And this is a common theme in our work, is that if we work at the margins and really try to make things better for people who are most marginalized, we're going to make things better for everybody. So how do we pull this together into an approach? Instead of just finding a solution for the patient, the first bullet here, we're going to try to build an alliance with the patient. And it's related to the work we're doing with our providers in the exam room about how they are explicit about race with patients, about what their approach is, and try to build an alliance in ways that expresses that we understand that the system is unfair. And for our staff to understand that, we still sometimes have to send people home because we can't see them because they came so late. But there's a softening in the whole dialogue of our staff having a different framework of looking at what happens to patients. The second step is exactly the same as the traditional method. We got to find them a solution to the problem. The third step, sometimes we can link our patients to community-based efforts to improve transportation, like in Boston, the T-Riders Union, where they can actually be part of the solution. And we also think that that's something that promotes health, is to link our patients to ways that can change, make social change for the better. And finally, advocating for policy change, trying to have a piece of policy work in every one of the social determinants that we're working on. So, Henry, you want to give a second example here?
All right, so the second example has to do with the observation that Latinx patients have a higher rate of diabetes, hypertension, social isolation, and depression as compared to their white counterparts. So in the traditional framework, again, we look at it as the patient problem. The patient is needy, needs more help, or she needs more help. And we try to respond individually by referring them to nutrition or individual therapy. And so the social isolation example, our reframing would be that the patient is not the problem, but the system is the problem. We know that immigrants of color, they're healthier in their home than than they are when they come here, sort of the immigrant paradox. Americanizing is bad for your health, it would seem. So we try to create interventions that rebuild social networks and that they had in the islands and for our Caribbean patients, and finding ways to get funding back in their hands and allowing them to define themselves or what's best for them. So one is to pay their participants to do their own cooking. There's supposed to be a picture there of one of our patients cooking their food. The second is to support participants obtaining their Zumba, so they themselves, we hired them to be instructors, so that way their peers helping them in their physical activity. And here's a group of our patients who went to the Mass Senior Action Council. They had a transportation council, and our patients made it up there to facilitate their own advocacy in the transit immigration rights. So what are the challenges here? Well, practically speaking, how do you develop data? How do you measure this? Defining the variables and then collecting the information can be very difficult. Can we get the quality department to see equity as an important component of quality and not just to see equity as an important part of quality? We're actually beginning to see that happen, and as mentioned earlier, care can't be safe and it can't have high quality if equity isn't involved. How do we find the time and resources to do this work? For many of us, it's been an add-on part of our job. Part of the struggle is when you have a full-time job that's taking up your time, and this is on top of it, it can be overwhelming. So gradually influencing those that have the power to distribute resources and create responsibilities to those people whose job we should be. And creating forums such as this conference today where we want to share and talk about these issues with other people who have interest in can offer us information. And then how do we influence large healthcare organizations and systems to work differently? Our examples how we work within partners to make changes and how we work across the nation through other collaborations.
So finally, how can you help your organization move forward? So there's a few suggestions, but I think the way we've described our journey, you can see that it's not something you can just turn the switch and make it happen. It requires effort over time. The first thing on here is trying to learn from the literature about what is critical race theory, learn about privilege, learn about our country's history and the history of medicine. Learn about your own community's history as it relates to these issues. So we found it's really necessary to invest some time. Secondly, learn and practice framing your organization's own issues and approaches with a racial justice approach. So you can go, there's a racial equity impact assessment that you can look up. We'll try to get out the resources for that. That gives you a systematic way of looking at an issue from a different lens and starts from questions like who's going to benefit and who's going to be hurt by this policy change or what is, and it's a way of seeing unintended consequences that may happen from something that sounds like a policy that would be an improvement. Learning from other, Race Forward is the organization that has that tool. And I mentioned before the Government Alliance for Race and Equity. It's a national organization of governmental entities that are working together on these issues. They have a lot on their website. They have a lot of concrete tools about how to approach issues in a different way, really walking you through things. Public health leaders out there like Dr. Kamara Jones and others that are in the national conversation trying to bring racism and health to the fore as an issue. A third thing, the IHI Institute for Healthcare Improvement that were part of their Running Collaborative, they kicked it off at the end of 2016 with a white paper that they produced called Achieving Health Equity. And you can find that on the web. It's a 6 or 7 page thing for healthcare organizations that lays out a framework of how you might move your organization towards health equity, racial justice framework. And finally, to do this work, you need to find some allies in your own organization that care about this and want to work together on it. And get together, work together, support each other, and make it happen. All right, I think we'll end there. Save some time for questions here. Yes.
Thank you.
Tom, if you would pass the ball back to Morgan, you can do that by right-clicking on my name and selecting Make Presenter. Perfect. Thank you. So Karen, I know you had some closing remarks, but it looks like this is our contact slide. If you wanted to get in touch with any of our presenters and ask them specific questions, you can. And if we have any questions, we can go ahead and take some. Kate, I think you've been keeping up with the questions in chat, so if you'd like to go over those. And while Kate's doing questions in chat, if you'd like to ask a question over the phone, you can press #6 to unmute your line. Kate?
Okay, so from chat, the only real questions we had were providing links. So the one question was, will you provide a link to the white paper, Achieving Health Equity? And I posted the link in chat. I also wanted to alert everyone that the slides do have several pages of resources at the end. Basically all the resources that were mentioned are in the last 2 pages of the slides. If you want to go to the event page and download the slides, you'll be able to see all the resources there.
Do we have any other questions?
The last slide that you put on before the thank you slide does have an example of a reframing tool. And I think it can be very useful. And this is just the kind of thing you have to try it out and practice using it on different policies in your organization.
Karen, did you have anything you wanted to add?
Sure. So I just want to give a huge thanks to all of our speakers today. This was so great. And to our audience for tuning in to think together with us about this important work. And as Kate mentioned, we did try to share a lot of great resources with you. And once you start looking at this on the web, there's just more and more and more. There's wonderful videos and TED Talks. And we did give you the link to the 9-minute video from Southern Jamaica Health Center. And it's just fabulous video. It's very powerful. So again, just thank everybody so much, and hope everybody has a great rest of the day, that we won't have too much snow tonight, and happy Thanksgiving.
Awesome. Thank you again, everyone. As you close out of the webinar, the evaluation will automatically pop up on your screen. If you don't have a chance to fill it out right now, or you're sharing a computer with somebody, you will receive an email tomorrow that will contain a link to the evaluation, as well as a link to the event page on our website, where you can find the presentation from today. Within the next few business days, a recording and transcript of this webinar will also be added. So thank you again, everyone, and have a great afternoon.
Thank you.
Thank you.
Thank you.